here today, and in general to have this long-standing collaboration, not just with Sabina, but with a number of people here at Exeter, Gail Davies, others, and particularly with the postgrad and postdocs. So it's been a really important part of my professional life, particularly when I've been at places where perhaps I don't have people to talk to. I didn't just say that. But anyway, I didn't have people who are directly sort of in the HPS kind of space at my institution. The talk today, with apologies to people who've heard a bit of it, it will go in a very different direction after a little bit, but it's relates to case reports, which is something I've been working on a really long time. But I want in particular to talk about the idea of use of case reports as a form of evidence in times of pandemic. And I thought that this was very relevant, particularly given the salvo that Sabina and John kind of sent off during the pandemic. Quick overview, again, so that if you want to zone out, you know where we're at when we get to the interesting bit. I just want to make some really grandiose claims, namely that evidence is produced in really diverse ways. Not all evidence is produced for the same kinds of purposes. I think this has been quite a sort of canalized view in philosophy of science for many years, although the blinkers have come off. In particular, whenever we talk about medicine, we have to talk about evidence-based medicine and that particular hierarchy of evidence, which has come to dominate it. I want to try to convince you not only that case reports are useful in general, they're useful particularly in times of pandemic, and give you three sort of sets of issues to think about. One is a cluster in a way of epistemic considerations. Second is more scientific in the sense that I think case reports help to further the science. And the third, roughly ethical. I think these are pretty intertwined. We kind of talked around this in a sense in Philip's talk and otherwise, John being a bioethicist being kind of one of the ways in which it came up. I think these are really closely intertwined, particularly in times of pandemic. I'll try to tell you why, but I think it'll become clear that they're actually sort of powerful sources of evidence. And not surprising, probably don't even need to make this argument, that the practices are what's most of interest and not some sorts of norms or ideals about science. So in particular, I got interested in this not just because I'm interested in case reports and have been for a long time, but I'm interested in settings where kind of the usual standards of evidence aren't going to hold because we need to actually do things. In general, I think clinical medicine works like this, but pandemics, of course, epidemics, outbreaks bring it to a head. But nonetheless, not just any evidence is going to do. And therefore, I think the recent pandemics, not just COVID, but a few others, give us real windows into how it could work. This is just the stock standard definition of a case report, namely some sort of formal, usually published summary, usually of one patient or a series of patients who are drawn together because they live together, because they're in the same community, something like this. I use the term case report to cover a sort of wide range of phenomena, but I'm also sometimes slipping and talking about case reporting, which is the way in which all the processes associated with how the cases are constructed come together and come to be used, both in more scientific undertakings, but also for teaching and other kinds of purposes. I've written on this a lot before, many of you have read this. But the key is that they are often deceptively a little bit like stories. They contain really rich data, very stylized, very formalized, not really clear why what's in it is in it, except perhaps to a real expert user. Very, very prominent, going back a long way. What you see is a significant drop off, and this is kind of the culprit among other things, I think, namely that when the so-called hierarchy of evidence that came to be known as evidence-based medicine comes into play, individual case reports are down towards the bottom as a very weak form of observational evidence. And of course, our preference is to have something like randomized controlled trials, or at very least meta-analyses or things like this up the top. And so individual case reports are like simply expert information or maybe the occasional anecdote. Very, very low in terms of evidence. So the criticisms sort of hinge on that. Namely, they tend to be very low quality. They seem to focus on things that are unusual instead of things that are typical or that perhaps make sense to do research on. They're very narrative, and so they're subject to selection and other forms of bias, recall bias. In terms of an entity that's publishable, they're considered to be really low end. Supposedly easy ways to publish. It's not like you actually have to do the hard yards of doing a randomized trial or anything else. And it's not the sort of thing you can fund for obvious reasons. So what we see is with the rise of EBM, we already saw flattening, and then we see a sort of decline, in part due to this heavy emphasis on trying at very least to have case controls and other things that appear to be more scientific. But then we have this weird kind of rebound that comes up, partially because now there are a lot of journals, but also in part because there's increased recognition that this is a distinct genre, that it has its place, and that there are standards. And I'll talk about this towards the end. We see now 200 or more journals dedicated to case reports. Some of them are really shonky. You know, they really should be on one, well, they are on those lists of things not to publish in, but there's lots of spin-offs of prominent journals, and there it looks like it's kind of trying to save the space in the main one. And you know, lots of scientific journals in general did this spin-off thing in this period, particularly now that we don't print journals anymore. So that 4.6 seems low, but that percentage is actually reasonably significant. It's a big body of work, and obviously it's doing some work. So what I'm going to try to convince you of is, in particular, the kind of work that it does in the case of pandemics. But more generally, I've made the argument that the idea here is that a case report in any one instance is aiming towards the future. It's looking at future treatment, future cases that might come, or research that should be done to try to figure out what was going on. By the time a case report gets written up, usually the person is either dead or they're cured, you know, the endpoint is in sight. But I think what's confusing, because of the narrative structure, because of all this detail, it seems like it's just a story about a person, right? But that's not what case reports are. Case reports are very much about this process of then using it to refine diagnostic conditions, identify subsequent occurrences, look at factors that cause you to be at risk, and prevention, either public health or particular classes of patients. And one thing I really focus on, and I'll keep hammering at in this talk, is this idea that they serve as the basis of hypothesis propositions. So they serve as the basis for people doing research to propose a hypothesis that then can be tested in something that looks like a more controlled way. It might be what the causative agent is, it might be what the right intervention is, whatever it is. But in some sense, the case report is defining a territory and narrowing a domain such that proposing a hypothesis becomes more reasonable. So the example I often use, because it's the one people already know, relates to what came to be AIDS, what was called gay-related immunodeficiency. So it's a connection back to the previous. But anyway, that there were these clusters of young men observed with symptoms that didn't make sense. In part, it was the clustering. They were super sick for young men. And eventually things like, very offbeat things like Kaposi sarcoma was observed. That's not the sort of thing you expect to see in young men, and so on. And so this rolls out from there into the story that we all know too well. But what's notable in some sense is the original article that sort of captured some of this data was published as a case report in MMRW, WR, which is the publication of the American CDC. And in there, it's very descriptive. It includes a lot of detail and so on. What I think, and here's where I'm not a real historian probably, but I can put that hat on, despite the fact that, for example, people have said this has become such a fundamental, you know, classic case, a reference point, defining public health issue of our times. The original case report only had 3 citations in the 1980s. So even things that come to be thought of as highly successful aren't really engaged with in the typical way that we expect if we use sort of typical bibliometrics, I'm sorry, still am jet lagged, bibliometrics. So I think we need to take it all with a grain of salt whenever there's this sort of pointing to these origin stories. The other lesson out of this though is, nevertheless, it was an extremely important thing to publish because it started what we have documented in the background, the discussions between physicians working in clinics for gay men who were seeing the same kinds of things. So very hard sometimes to capture the activity that comes with case reporting because it doesn't take the form of our traditional metrics that we tend to use in HPS. So keep that in mind. You probably know more of that background than any other probably case report that you're familiar with. In a longer version of this and in the book that I'm still finishing, we talk about the idea that case report processes are more like abduction, thank you, Stefan, for mentioning it earlier, than they are like induction and deduction. This maybe is a straw man for you if you were indoctrinated into analytic philosophy of science. Somehow you have to say why they don't follow law-like structures. I'm less interested in the negative argument than the positive one. I think there's something really useful associated with thinking about this as abduction. And I think more generally in philosophy of science, we haven't taken abduction seriously enough. And make of it what you will. Peirce has different versions of what he thinks abduction is. But I think I really like some of the ways in which he puts the hypothesis testing bit of this story. And in particular, this idea that you start somewhere through abduction. It's not the case necessarily that the hypothesis is the most probable, but it needs to be informative. And so there's a sense that within the practices, within the specific local context, there are going to be some hypotheses that make more sense than others. And that's one of the domains that I think is inscribed by the case report. The second kind of way that I want to think about it more generically is to think about what happens with case reports as involving strategic reasoning, and that it often is deeply local and context specific, because this metric, if you will, of being well chosen or informative requires local knowledge about what's going on. I also think there's a lot of strategic reasoning that goes on, and some of it is perhaps for not particularly good scientific reasons. It has to do with what you have close to hand, what resources you have, what's more likely to be informative, and so on. So all of this is part of the kinds of investigative strategies that researchers use when they start to work from this instance of a case report. And finally, part of the strategy is this trade-off between something that's meaningful in research, but something that's actually going to help when you see someone else sick with a similar condition. Finally, this idea of relative to background knowledge is it needs to actually be testable in some way via practice. And in this, it's not the case that usually you're inducing any of it, you're waiting for another instance to appear. And in particular, the other thing I like about abduction is the creativity that is allowed, the idea that novelty can be incorporated in, and that it allows that kind of freedom and flexibility around what we consider to be the account of what's going on in a particular instance. Finally, I think the generic kind of claims I want to make about case reports are that they foster dialogue, and in particular this idea that part of why they're put out there is to induce other people to start looking for it, to talk about it, and so on. And in many ways, the measure of something being successful probably is that dialogue, which is very difficult to track. And I think the abduction also provides a really good kind of window into this idea of pursuit worthiness, which is also socially constructed between those in dialogue. I think the important takeaway about abduction that I really want to get across here is that it's not looking to evaluate a truth claim. It's not looking to tell us what is the case. It's looking to say, this is likely the best strategy. And so that's what makes it fundamentally different from other forms of reasoning that we sometimes see in science. Sorry, I did a really terrible job with these slides. Okay, so the first thing I want to talk about then is the way in which case reports during times of pandemic can be epistemically valuable. Now, I think these cross over a lot, and it's sort of arbitrary what I've put in different slots. But let me try and use this one towards the epistemic end. The problem with pandemics is multifold, but it's in particular studying phenomena that are rapidly changing, in part because maybe we haven't pinned it down, talking about that in a minute, and often under less than ideal circumstances, because it's rapidly moving, because it often happens in places that have less resources or whatever else. And this means that the usual means of sort of doing science doesn't have time, doesn't have grounds to be used. And so in particular, then it requires often a public health response based on the best possible information. So you need to at least have something. You need to have a starting place, if you will. Now, this is the point that Sabina and John made in this piece, in this nice special issue of HPLS, that one of the problems with COVID was that there was this attempt to reify the virus itself, despite the fact that it was highly unstable. And that kind of reification is something we see typically in science. You have to hold something fixed in order to study it. But in particular, they want to fault that tendency because it led to really problematic assumptions that got embedded in the data, got embedded in the modeling, which in turn then flowed on to the public health considerations. And so, you know, the quote from them was something like, few systematic provisions for capturing changes in phenomena and responding to the temporality and specific provenance of data were present, or something like this, in the story of COVID at the point at which they were writing. What I want to say is case reporting can actually help us with that. And I think, you know, there's at least two things to say. One is, you know, they are available, they can be used. And second, they can be systematized in a way that's appropriate for them to count as evidence. So as an example, we can think not about COVID, but about the H1N1 pandemic in 2009. Here we saw case-based data in principle should have been useful. However, we also see all the problems with using case-based data. And in this particular case, the World Health Organization asked for case-based data by country. And they had this brilliant idea that seems like it should have worked. I mean, everybody's going to say it was ridiculous, but to ask each country for their first 100 laboratory confirmed influenza cases, right? As though that was a static kind of norm. Now you can already start to see laboratory confirmation makes all sorts of assumptions about resourcing, who actually goes to hospitals, very different in different countries and so on. But the idea was they're trying to get around some of the other metrics which make even more assumptions. And so the idea was to generate sort of early understanding of pandemic progression. What resulted was wildly inconsistent data. And even despite all their attempts to standardize it, they ended up with really different kinds of outcomes, which, you know, anyone who knows anything about social domains would have predicted. And what we see here is sort of the symptom onset date is really stretched out. For example, in Africa, which is the yellow, I know that's difficult to see. We also see that Europe, they just churned out more and more samples. They were overachievers and sent a lot more than the 100 they were supposed to. We see that in certain countries in Asia in particular, there just weren't that many cases, but of course there were cases. They were just being cared for at home. And ways in which using metrics, particularly tied into labs, is problematic. So the conclusion from this was that standardized data alone is not sufficient, or often it's actually not very useful. And the people writing up this said a better approach would have been identify critical questions, standardize data elements and methods of investigation, and create channels of communication, surprise, surprise. And all of those things are what, in some sense, case reporting would have allowed you to do. So this looks at first like it's case reporting, but it turns out to be simplified to a point where the data collected isn't as meaningful. And so I think the parallelism is pretty clear. You can't just get data without asking questions. The question there maybe was, you know, who ends up in hospital, but you need to also be careful that you're getting enough of the background context to understand what you're looking at. And just by way of standardization, the people who are advocates of case reports have attempted to come up with international guidelines and increase sort of completeness, comparability, and so on. This goes back, sorry, I really am like 10 years, more than 10 years. But what I think they're also looking ahead to, obviously, is combining case reporting through machine learning and other things. And so there is this sort of standardization that can be leveraged, but hasn't been adequately leveraged. So the second point I want to make is having to do with how case reporting can actually create better science. I think too often there's this attitude that case reports are what you do before you start doing the real work, but instead I think there's good evidence about how it can work at important stages, particularly, again, pandemics, but outbreaks. And so in this case, I'm looking at outbreaks where it's not known what the agent is, what the etiology is. And basically, there's lots of standards that have been articulated for what you need to do in these instances, but they're all coming out of highly resourced kind of environments. So there's lots of talk about needing better diagnostic tools, needing better laboratories. We need to improve the clarity about who's responsible for figuring out who's sick and set performance standards. That was an Australian one, very Australian. But not a lot of thinking about that none of this is relevant outside of heavily resourced context. And so instead, a group of researchers that's involved in developing countries did this complicated kind of attempt to come up with a few outbreaks that they thought were really characteristic of the kinds of problems that they see all the time on the ground, and then did oral history and all sorts of other things to reconstruct what actually happened. So that's why it's only 7. And out of this, then they came up with sort of lessons learned. And in particular, they noted that what they saw a lot was incomplete or delayed descriptions of patients, lots of comorbidities. So very hard to figure out what a causal agent is when you've got, endemic hepatitis A and HIV, and cholera or whatever else. And in a lot of these locales, these people have these overlays of multiple health problems, particularly ones that can be picked up in the lab. So it's difficult to figure out, when you're seeing something other than the background conditions. All of this sort of combines to lots of inappropriate diagnoses that prove later not to be true. And even when you partner internationally, which all these 7 ones did, there's kind of a limited capacity to ship samples in such a way that they don't end up tainted in some way or whatever else. This domain, as they note, has a heavy focus on lab results as the sort of the end point of these kinds of outbreak investigations. But as they say, they're just sort of part of the picture and in fact can be extremely misleading. And their sort of big pitch here is learn from history. And this is better than the science thing a few weeks ago. They're calling for things like publishing descriptions of how to investigate this, even where and particularly when the outbreak is not determined. Second, that they think that these kinds of descriptions, they're not using the word case report, can serve as an update or a touchstone for the scientific community to do additional research, and that the WHO emergency monitoring system needs to serve as a database for all outbreaks, not just those that were neatly solved, because there's a tendency for stuff only to go in when there's an answer. You'd think that that would be obvious, but this obviously in their field isn't. This is a 2023 article. And what I think here is really noticeable is they call for a whole range of things, which are exactly what robust case reporting can provide. Complete immediate descriptions of patients gathered in a systematic manner. Low tech, you could do it, possibly. Disentangling of confounding comorbidities, you need good histories. Not jumping to a diagnosis or to etiological decision until you know for certain. The need to ground hypotheses in local conditions rather than assuming patients are just sort of like the textbooks. Using multiple forms of evidence gathering in an iterative way. Finally, using a multidisciplinary team, including they want social scientists out there talking to people. So this is very interesting to me for obvious reasons. The third way in which I think case reporting could be helpful, and it doesn't always work this way, but I think there are some sort of building blocks towards it, is that I think it can foster a lot more equity. And I mean that in at least 3 senses. One is equal scientific attention to where there is real need, where there are real problems. Second, greater amount of resources going to where the need is. And third, authorship, that people who are on the ground doing important scientific work in some way get credit for it. I'm not going to go into sort of models of authorship. It could be various forms, right? And so the ProMed system that I have up here is an email-based, pretty simple. It gathers observational on-the-ground reports of public health events for which the diagnosis has not been found. Various kind of complications politically mean it's a closed network for submitting, but it's open for everyone to see. So it's only open to people who are working in epidemiology because they've had all sorts of problems with people hacking in, which is strange. So as compared to typical systems, this is a more equitable system, a lot of practitioners would say, because it just tells it like it is. It tells you what's going on the ground. And so they also bring in things from media reports, they bring in things like the sources of evidence are quite diverse. It tends to be pluralistic. It also tends to be very inclusive, some would say to a fault. So there may well be things in here that aren't actually infectious diseases. But the advocates of this sort of system would say, so what? Then we don't worry about it once the evidence becomes clear. What you see is undiagnosed disease events, undiagnosed kind of funny, where they don't know what the disease entity is. You look at the dots and you can see it generally is under resource locations, right? And it's important to know that this isn't distributed equitably or uniformly, right? And so what we see is, I think, if we think about this in terms of case reporting, a few things emerge. One, it starts to push us to broaden our definition of what counts as science. Currently, who publishes out of an outbreak tends to be the lab internationally in the formerly colonialist home that was collaborating with the locale where the outbreak occurred. And they're the ones who have the funding. They publish, all their names are on it, and you see none of the people on the ground working with the patients, collecting the samples, collecting the data, and so on. And this in many ways is highly problematic. Part of this is because obviously publishing a lab-based, evidence-based result is much easier than publishing all sorts of other forms of things. It is the case, obviously, that those on the ground often are overwhelmed and they don't have resources or time to generate certainly the traditional peer-reviewed publication, or even probably very robust records of what went on during the outbreak. One of the things here is that this evidence is very early stage in the way we typically think about science, and it doesn't tend to directly be the thread to the answer or the outcome. And as one epidemiologist put it to me recently, these kind of case reports just disappear. Even if they kind of existed in that database through email, once big data kicks in and lab results are there, you get tidy publications, was the word that she used. And I like this kind of account because I think it does reveal a sort of tension. I think there's a deep scientific need to encourage this kind of case reporting. Médecins Sans Frontières did an analysis a few years ago, which sort of showed there's all this clinical experience that gets lost because people in lower resourced areas don't write it up. And there's a whole range of reasons, most of which you could guess at. But a lot of the reasons why it doesn't get written up is precisely why it should. Because often people are treating these kinds of patients in precisely those sorts of areas. And best practice standards are coming out of fancy hospitals in very developed countries. And dare I say, a lot of parts of even the developed world started to face needing to make these kinds of decisions during COVID and had very little basis on which to do it. We're used to being able to demand, as many x-rays, tests, lab results as we want. When that started to be stressed and strained, there were no best practices. So finally, let me just skip this one. I think there are good philosophical reasons to encourage case reporting that these kinds of cases show. If you consider standpoint epistemology, basically any form of it, the idea is that we do need to be careful about the ways in which our social and other situatedness may put blinders on us. And what I want to say is, in many ways, medicine has blinders all of the time towards privileging certain forms of medical research and clinical care. And inclusion of much more diverse practices could allow really important shifts. And I think those shifts include away from evidence-based medicine, appropriate in some instances, not appropriate in a lot of clinical cases, and also away from narrow sort of biological understandings of disease, which kind of had their heyday, but have come back again with genomics and precision medicine and so on, to more contextually, socially grounded understandings of wellness. People care about being well. Second, that there are diverse and context-specific standards of care. And third, that science is practice and process and not product. So what I've tried to say here is that case reports are really valuable, not just in pandemics, but beyond, and to never overlook that hierarchies of evidence can be very exclusionary. Lessons for philosophy of science, not surprisingly, it's not all about explanation. We're life scientists, we focus on the life sciences, we kind of know that, but I think it's really important in these domains to not make it more scientific than it is, in the sense that sort of traditional analytic philosophy would have science be. I think focusing on things like abduction give us this window into these other stages of science that we traditionally neglect. And it wouldn't be a talk from Rachel if I didn't put in the vote for practice. I think the interesting thing about medical case reports in this way is that it's in this kind of very interesting space that I think often gets overlooked. We need to try to see what goes on in that space beyond what gets published and the final products. It is this sort of formative space. And hence I think case reports are interesting because of what they do. Less what they are, kind of on the page or otherwise, but what they do and what they could do, the space that they could create, particularly for more equity in research in developing countries. Thank you.